So John Andrews is our vice chair for education, but he's taking a well-deserved vacation. So I'm stepping in for him today to do an introduction that I'm delighted to give for one of my favorite medical educators that we are so lucky to have recruited to come here to the University of Minnesota, and a great person to kick off our new Grand Rounds time slot. So usually I don't need notes. I'm pretty good at speaking off the cuff, but Bob Englander is so accomplished that I actually will refer to his bio to tell you a little bit about him. So Bob came here to Minnesota to be the Associate Dean for Undergraduate Medical Education. So he's in the medical school, but he's a pediatrician, so he's in our department. So we're doubly lucky there. So Bob Englander received his MD degree from Yale, a master's in public health from Johns Hopkins. He did a pediatric residency at Children's National and a fellowship in peds critical care at Mass General in Boston. He worked at the University of Maryland as a peds intensivist and was a director of undergraduate medical education while he was there. He then spent some time in Hartford, Connecticut, where he was a medical director of inpatient services and a division director for a division of hospital medicine. Also served as a VP and senior vice president for quality and patient safety. He was an associate program director in their residency program there in Connecticut, so got some experience both at the residency level and at the medical student level. He spent time overseeing competency-based education. He served on the board of directors of the Association of Pediatric Program Directors, APPD, a group that fellowship directors would be familiar with. And he was also an integral member of the Pediatric Milestones Working Group, those new framework that we're all familiar with through the ACGME. In 2011, he moved to the AAMC, where he really worked on competency-based medical education and was the project lead for a project that's near and dear to our hearts, the EPAC project, Education in Pediatrics Across the Continuum, which is where I first came to know him. And for those who need a reminder about EPAC, that's our national pilot project where we aim to advance medical students through their training from medical school to residency and out into practice based on the achievement of competence, not on time spent. He also spent time as a project lead and was on the drafting panel for the Core Entrustable Professional Activities for Entering Residency, which you might hear described as CAPERS. After his time at the AAMC, he spent some time at George Washington University and also worked as a consultant for the American Board of Pediatrics in their MOC Part 4 area, and working on the development of entrustable professional activities for pediatric specialty at the residency and fellowship level. So he is a real national and international expert in medical education. We're so lucky to have him here, and he's going to start to help us build our educational vocabulary as we explore these new frameworks for thinking about how our learners are doing. So without further ado.
Thanks so much, Emily. I hope everybody can hear me. Good morning. So I'm going to start with a assessment of the audience. That's what I'm supposed to do to start, see how you all are. So the assessment is how competent are you in competency-based medical education? So I'm going to give you 5 answers, and then I'm going to go back to them and ask you to raise your hand when I get to yours. So the first answer is, what is a competency? The second answer is, I finally understood competencies and you threw milestones at me. The third answer is, I get competencies and milestones, but what the heck is an EPA? The fourth answer is, I am competent in competency-based medical education. And the fifth answer is, get off the stage, Englander, I should be giving this lecture. Okay, so how many people are at the what is a competency stage? Okay, how many of you at the I got the competencies, what's a milestone? I get milestones, what the heck's an EPA? I'm competent in competency-based medical education. Get off the stage, Englander. Awesome, thank you very much. Oh, okay. All right, so what I would say to you is just judging, this will be the right topic for today because most of you sort of felt like you sort of get this except for you're up to the EPA level. So what we're going to talk today about is entrustable professional activities as an organizing framework for assessment of competence. And I want to start, well, I'll give you my objectives. Also, to let you know that I have nothing to disclose, no financial disclosures. Can you imagine? I don't know anybody who makes money in competency-based education, but so nothing to disclose. The objectives are to, first of all, develop a working knowledge of EPAs in the context of competency-based medical education. And then I want you to have a working knowledge when we leave about the relationships between EPAs, competencies, and milestones. And finally, we'll apply the concept of EPAs across the continuum and show you, hopefully, how we're doing that from undergraduate to graduate medical education to subspecialty training and ultimately as a potential template for maintenance of certification. So I'm here to tell you a story, first of all, to put this all into context for you. Because a lot of people feel like, well, first, the ACGME came out with competency-based medical education. That was a lot for us. Then there was this milestone thing, then the EPAs. And it's actually all part of one movement. The one major movement here is shifting from the old structure process model, the model that was first really described by Flexner in 1910. We're basically using that same model 106 years later, to a model of competency-based medical education. And the major difference is to go from fixed time, variable outcome, education and training, to fixed outcome, variable time, education and training. So the only thing that we're certain of is that if you put people through a fixed time model, at the end of that model you get variable outcomes. It's the only thing that we're certain of. And the result of that was an increasing gap between the expectations of people at the receiving end of learners and their actual performance. So Emily can tell you, and most program directors can tell you, that there is often a gap between what they need and expect residents to do on their first day of residency and what residents are actually able to do without direct supervision. And the other scary point is that even though there's a gap, they're still doing it. There's great evidence that residents are doing a lot starting day one, even without our having documented whether that's something they're able to do without our being in the room, without direct supervision. So a lot of gap, and that's what drove this movement. The second piece of this, the second thing that I think was a driving force, is the concern about a growing expansion of the notion of what it means to be a doctor, and we'll get to that in a minute. So this is the major shift. Everything else, the competencies, the EPAs, and the milestones are a part of this frame shift from structure process education to competency-based medical education, and hopefully I'll show you how that fits. So there's basically a four-step process to moving from a structure process educational system to a competency-based education system. And the first one is this concept of defining the outcomes. You've got to begin with the end in mind. And the outcomes in our case that the ACGME really got us started on, focused on, were designed to say, what does a 21st century doctor need to be? What abilities does that doctor need in order to serve the public? And we finally are at a place where there's common vision across this country around what it means to be a physician. And I want to make a point here that the developmental trajectory in competence is actually one towards mastery. Competence is a threshold model. What we're trying to get to is at least a level that you can perform either without direct supervision in residency or without supervision in practice. But all of our goals sitting here is not to be competent. Our goals are to be masters in what we do. And the concept of a competency-based system is one that actually projects out and lets you see what it means to be a master. And we're trying to build that mastery in 8 domains of competence. So for those of you who are in the ACGME, how many of you do mostly graduate medical education work? Mostly graduate medical education work? How many of you do mostly undergraduate medical education work? And how many of you do both, a combination of both? Okay. So for those of you who do mostly graduate medical education, don't get worried now when I say 8, because you're used to 6 domains of competence. And I'm going to show you where those 8 come from and how they're related to the ACGME 6 domains. So I would argue that we really are at a point where people across this country agree that this is the core of what it means to be a doctor. And the first 6 that you'll notice, so patient care, medical knowledge, systems-based practice, practice-based learning improvement, professionalism, and interpersonal communication skills, I hope are familiar to those of you who are involved in graduate medical education, because those are the ACGME 6 domains of competence. What we did while I was at the AMC, we actually looked at 158 competency lists representing over 4,500 competencies to try and figure out the most robust list we could get, but whittled down to the core meaning. And what we found was that those 6 held really well, and this was across countries, across professions, across the continuum, medical school, training, and residency. And we used as our reference set the original ACGME list that was published in 1999 and then updated in 2012. So that was our basis. And then when we saw a bunch of competencies that weren't really covered in that list, and they fell out into these two domains. So the first one is interprofessional collaboration. And while it was in there in the ACGME framework in some interpersonal communication skills and some of the systems-based practice competencies, we thought it was really so key to being a 21st century physician that it really should be its own domain. And that was particularly on the heels of a publication from something called the Interprofessional Education Collaborative, which was a collaborative of 6 of the main healthcare programs to come up with competencies. And that's what we based this list on. And then the last was this personal and professional development. How many of you are here familiar with personal and professional development competencies? Anybody? So these actually came out of a project that we did with the Association of Pediatric Program Directors, where we said to them, you've had 10 years to look at the competencies. What's missing? And we got people to submit literally index cards with what was missing, and there were 800 submissions, and those 800 boiled down to 8 competencies, basically, in this domain. And they include things like knowing one's limits and seeking help. Confidence that puts patients and families at ease. Trustworthiness. Leadership. The ability to manage stress. The ability to balance personal and professional responsibilities. And once we used the pediatric domain, personal and professional development, it was amazing that it really pulled in almost all of the competencies that were still left straggling, particularly the ones from other countries where they had actually attended to these competencies in various ways. So I would argue with you right now that we are at a point where, and the competency set, this 8 domains with its 58 competencies, got named in the literature, not through our paper, but as the Physician Competency Reference Set, the PCRS. And the PCRS, as you can see, has its foundations in the ACGME competencies and is now the basis for what most med schools are using for their competencies. So that you can see that this is really the first time there's alignment from undergraduate to graduate medical education and beyond, because, by the way, the Outcomes Project was not just the ACGME, it was also the American Board of Medical Specialties. So we now have essentially the undergraduate schools, the ACGME, and the American Board of Medical Specialties all aligned on the basic core of what it means to be a doctor. So that's step 1 to move from structure process to competencies. The second step is that you now have to say, well, okay, if those are the competencies, how do I know when somebody's competent, proficient, master, novice, or an advanced beginner? How do I know where somebody stands? And that was the Milestones project. And so I had to use this. I love this because I thought, this is a first-year student. I won't do it. Second year, I can't do it. Third year, I want to do it. Fourth year, how do I do it? First year intern, I'll try to do it. Second year, I can do it. Third year, I will do it. Chief resident, yes, I did it. And then back to a faculty. I won't do it. Exactly. So that was the second step. And it was interesting because I think if the ACGME had to do it over again, we probably would have done 2 things differently, matched these 2 processes, named the competencies and developed their milestones, because there was a lot of frustration in the community as appropriately to have the competencies and no guidance on what actually competence looked like. And so I think, I would ask Emily, but I would guess that most program directors as hard administratively as the milestones are actually finding it an easier way to talk about competence and finally getting a picture of what competency looks like. So that's the step 2, is to define the performance levels, and we've done that. So then step 3 is the next major hurdle. So once you've defined your outcomes and you've defined the performance levels, the question is, how do you assess them? And most of the rest of this talk is going to be on considering entrustable professional activities as a framework for that assessment. And I'm going to go through with you why that's true. But I want to just tell you the final step, which is step 4, is evaluating the effectiveness of your competency-based education. So once you've made this switch, you got to say, what's better? Or are things better? And I think that's going to be really incumbent on us to do. And the ways in my mind to do it are through looking at changes in burnout rates, changes in faculty satisfaction, and changes in patient outcomes in this country. Because right now, our patient outcomes are pretty miserable overall. If you look at most of the World Health Organization outcome indicators, we are between 27th and 33rd out of 33 industrialized countries on most major indicators. So we have a long way to go. And I would say that while it's not entirely the education and training system that gets us there, there are a lot of systems issues, it's a large part of what we need to do better. Before I get into the assessment piece and the EPAs, I just want to make sure we're on the same page about the language. So this concept of a domain of competence also has been called in ACGME language a core competency. And what those are these broad distinguishable areas of competence that in the aggregate define what it means to be, in our case, a physician. So that's patient care, medical knowledge, right? It's those 8 things I talked about. Those are the domains. Then the competencies, which in some literature is also referred to as sub-competencies, so I apologize for that confusion, but in most the literature, competencies are these things that fall in the domains, and those are observable abilities of health professionals. Observable abilities of health professionals that require the integration of knowledge, skills, values, and attitudes, okay? So they're abilities of individuals. That's important because that's very different, and I'll show you how, from EPAs. And then finally, a milestone is a defined observable marker of an individual's ability along a developmental continuum. It's that level of performance: novice, advanced beginner, competent, proficient, master. Okay? So an example would be patient care would be the domain. The specific competency in patient care is gathers essential and accurate information, and the milestone in pediatrics for a novice is that this is a learner who relies on a template to gather information. They often gather too little or too much information. They recall information in the order elicited without the ability to gather, filter, prioritize, and connect pieces of information. Okay? So now you have a picture of what somebody looks like, and it turns out we have 4 other milestones if you wanted to go look at them to show what an advanced beginner, a competent, proficient, and master looks like. An entrustable professional activity is now an important routine care activity that define a specialty. It's the essential activities of your specialty. If I follow around a general pediatrician for 2 weeks, what do I see her do? That's what an entrustable professional activity. So remember, we said competence, a competency, ability of an individual. EPA is a work task. It's an essential work task of a professional. They should be observable and measurable. They require the integration of competencies within and across domains to perform. So that's another critical piece. And finally, the entrustable means readiness to perform without supervision, if you're talking about GME, or without direct supervision, if you're talking about UME. And this work came from a guy in the Netherlands named Ole ten Kate, and Ole is a remarkable guy. He's actually an MD, but went right into his PhD work in education immediately following his MD, and has been working in medical education since. And he was frustrated by he liked competency-based education as a construct, but didn't like the assessment techniques, found them very impractical. And so he literally followed, and he worked with an OBGYN, a guy named Fedashil, and he followed him around for 2 weeks. And at the end of the day, they said, this is really what I need you to be able to do. This is what I need to be able to trust you to do. And that was the first paper in 2005 called The Entrustability of Professional Activities that he wrote. So EPAs, to me, provide a very practical framework for assessment of competencies, because competencies focus on the single ability of individuals and not on the integration. And when I watch learners, when I am doing things, I'm doing things that integrate functions. I very rarely am just doing that one function. And so everything sort of has to work together. EPAs focus on this integration. And then the other piece that I love, and we're going to spend a little time on this, is the concept of entrustment, bringing this concept of entrustment explicitly into the workplace. So all of you know that we do implicitly trust. We make implicit trust decisions all the time. So I'm now a hospitalist. So I might go home and say to a resident as I'm going home, please call me with every admission. Another resident, I might say, please call me if you think a patient needs a consult, or if they're deteriorating and needs to go to the ICU. If you get a new admission, let me know if you need any help. Right? Those are two very reasonable things to say to a resident, and they have very different implicit trust decisions. Right? On one hand, I'm saying, I trust you to call me with everything, but I need you to call me with everything. I don't trust you to manage the patients on your own until I come in the morning. In the other setting, I'm saying, I trust you to do that. I trust you to look at new admissions and manage them on your own until I get there, unless you feel there's something that you need to call me with. Very different implicit trust decisions. So we've been making them all the time, and the question is, how can we actually find a way to make them in a more explicit and a more objective, or at least behavior-based way? So these are some of the important distinctions that hopefully we're getting right now. We talked about the fact that competency, the unit assessment, is an ability of an individual. In an EPA, it's the outcome of an activity. So it's an essential task outcome. Competencies become context independent, and that makes assessment difficult, whereas EPAs are embedded right in the clinical context. Now, sometimes that's a little difficult because you'll say, well, do I need, as a pediatrician, to assess that EPA with a neonate, an infant, a toddler, a school-age child, a pre-adolescent, an adolescent, and a transitioning adult? And my answer, I'll hopefully share with you, is going to be no. I don't think you need to do it in every context, but you probably need to do it in more than one. How many, we don't know exactly yet. And finally, competencies address the knowledge, skills, and attitudes of a specific task, whereas EPAs are multiple competencies that need to be integrated. So I'm going to stop there for a second, just say, hopefully at this point, I would hope that you understand the 4 steps required to move from structure process, where we used to be, to a competency-based system of education. That's number 1. And number 2, that you have some idea now of the differences between competencies, their milestones, and EPAs as a framework of assessment. Are there any questions about that right now? Don't be shy if it's confusing. Okay. So what I'd like to do now is sort of march through each of the letters in EPA and just talk a little bit about what they mean. So we said that the entrustable professional activity, refers to this ability to do it safely and effectively without direct supervision in the UME space, or without indirect supervision, or without any supervision in the GME space. And they bring this concept of trust and supervision into the equation, which allows inference about competence. But the ultimate trust decision is a yes-no decision. That doesn't mean that you can't have great conversations as you're moving towards that about what you're trusting somebody to do or not. Here's the issue, though. Part of foundational to making a trust decision is trustworthiness. So what we decided, trustworthiness, I told you, is one of the competencies in the personal and professional development domain. And we decided that it actually is foundational to every EPA, that if you're going to make a trust decision, you probably need somebody to demonstrate trustworthiness. And Tara Kennedy is a pediatrician educator from Canada who followed teams around to try and understand how faculty make decisions about residents predominantly. And she ended up saying there were basically four things that they needed to see. The first was the ability or level of knowledge, skills, and attitude. And what I will tell you is, to me, that is EPA specific, right? Your ability to demonstrate the knowledge, skills, and attitudes is probably EPA specific. But the other three, I think, are less specific and more generic to just being trustworthy. Conscientiousness. Does that person follow through? Again, I'll use my world, the hospitalist world. If we say on rounds that we're going to follow a blood culture, perform a consult, or ask for a consult, or follow up on some radiologic study, do I trust that that resident or student is going to be able to do that and answer the question of where we are at the end of the day? That's what conscientiousness refers to. The third bullet here is telling the truth, the absence of deception. This is a really hard one, because usually in our systems right now, we only see this when there are egregious errors in this. We rarely see people who are struggling with this because of very reasonable reasons. So, for example, some people feel that they're in a system where it's not okay to admit that they don't know something, that they're wrong, and so they fudge. And those are people who can probably be remediated. A pathological liar can't be remediated, but somebody who's in that situation probably can. We don't always see them until it's too late for remediation. And then the last one, which I think is among the most important thing, is knowing one's limits. Does somebody know their limits and seek help when they see their limits? And this, to me, is really important around that issue of context and how many contexts do we need to watch an EPA in. And the reason I say that is because so if I think again about that issue of, so there's a EPA for undergraduate medical students called Perform a History and Physical Exam. So imagine if I need to see them do that for the newborn, the neonate, the infant, the toddler, etc. There's no way we can see all of those things. But if I know somebody is discerning, if I know somebody knows their limits, then I know they're going to come to me the first time that they're with a neonate and say, hey, I've never examined a neonate, will you come into the room with me? I may have entrusted them on that professional activity, but I did so knowing that they're going to come get me if they need help. So discernment is a really important one. So here's my question for you. How do you know your learners are trustworthy? Is there anything that you're doing currently in your fellowship, in your residency, in your program for students, in your peer evaluation? Is there anything that we're doing to explicitly look at trustworthiness? So what I'm going to ask you to do is just maybe find a partner who's sitting next to you for a couple minutes and just talk through, is there anything that you know that you're doing explicitly here to measure trustworthiness in your students? If not, what are you doing implicitly? How do you know if somebody's trustworthy or not? So take a couple minutes to discuss it with your neighbors. Okay, so so I had the benefit of sitting with Emily, who is obviously a residency program director, and hearing about the peer reviews that they do within the residency program, which is an explicit way to get at these points, particularly around discernment and truth telling. Other folks, anybody have other explicit ways that they do this? Anybody else using peer review or, yeah? Right. So for those who couldn't hear, Joe's point was that there's one of the things that happens, and actually Tara Kennedy talks about this, and she calls this backstage supervision. So the concept here is that you hear resident students provide facts all the time, and you're doing fact checking. You may not be explicitly saying to them, by the way, I'm going to check all of your facts in X today or Y today, but you're doing it. You're doing the blood culture checks. You're checking the chest X-ray to see if, in fact, the results that were presented to you were the true results. So that's called backstage supervision, and it's a very effective way to find out about truth telling. And again, when somebody doesn't tell the truth, it doesn't mean they're dishonest as a core issue. All of us do things at different times under different circumstances, and you have to follow that up. But if you don't see it, if you don't look for it as a pattern, you definitely won't find it. One other story. So one of the schools that I spoke at, I asked this question. And it so happened that 2 years prior, they had moved from a totally implicit way of looking at trustworthiness to an explicit way by peer review. 4 peer reviews per year per student. So they went through peer reviews where 4 times a year, where 10 of their peers, anonymously, but in a team that they worked in, but so that they didn't know which of the 10 did this, 10 of their peers did a peer evaluation on issues of communication, teamwork, and professionalism. And in professionalism, they spelled out specifically some of the components of trustworthiness. The school has about 180 students per year, and they went from discussing 1 or 2 students per year in their advancement committee around issues of professionalism to 4 to 5%. To 4 to 5%. So went from about discussing 1 to 2 per year to 8 to 10 per year. And the issue that I would say there, and by the way, most of those students ended up doing fine, were able to be counseled, remediated, were able to be enriched so that they understood what the issues were and then were able to mitigate them. And I would argue that by doing this implicitly or not at all we're doing is moving these problems or concerns into residency, and sometimes in such an embedded fashion in that person that they're not remediable. So I think for us to get into this business of EPAs, we should be thinking carefully about how we explicitly measure trustworthiness. So the P part, the professional, talks about the activities. It's a modifier of activities, right? Professional activities. And it relates to either an area of practice like a specialty, so pediatrics, internal medicine has published EPAs, or the scope of practice, such as what profession you're in. So there are public health professionals who have used the EPA concept, nurse practitioners, physician assistants have used it. And finally, I added learner's place on the continuum since we published EPAs for undergraduate medical education as well. So those are the professional. And then the activities, as we talked about, represent that essential day-to-day work, the stuff that I would see if I followed you around. They lead to a recognized outcome, should be independently executable, observable and measurable units of work, and require integration of competencies. So what we're going to do now is I want you to end this, I want to, as we go through this, make sure at the end that you really understand the relationships between EPAs, competencies, and milestones. And I'm going to do it by working through an EPA example with you, and hopefully you all have the handout that is starts with a worksheet. It's a description of a handover EPA. Do we have some more down here? Anybody not have a handout? Oh, a bunch of people.
There won't be enough.
Okay. In the interest of time, I'll start, but when Emily comes back with them, I'll have you raise your hand again if you don't have one. So the first thing when you look at an EPA is we create an EPA worksheet, and this is something that originated again with Ola Tenkate. We adapted it here. So you start with just the title, and the title is actually important. It should say what that activity is. It should not have a lot of value judgment in it. It shouldn't say things like appropriate or effective or easy or hard or we don't know exactly what those mean. If it does have one, so it like manage common conditions, which we sometimes see as an EPA, if it does have that, then in that case, you should probably define under the brief overview what those common conditions are. Are we out? Okay. Wow, that's too few handouts is a great thing. Okay. So the first thing you do is the title, and then you do a description of the activity, and you can see that in there, and we'll walk through each of these for this handover EPA. Then you want to map it to the competency domains. So if you want to think about what are the competency domains in which that are critical to being able to perform this EPA, and then the specific competencies. And you really have to be only the critical competencies here. It's very easy to say, handover, right? It would be easy to argue that it relates to almost every aspect of the 8 domains of competence that we talked about. You could find an argument for most of those domains and many competencies. What this boils down to is what are the critical ones? What are the ones without which I can't trust, or with which must be present in order for me to trust, either to do this without direct supervision or to do it without unsupervised. And then the next thing you have to do is a curriculum. Okay, so if those are the competencies and the functions, what are the learning objectives? What's the timing of the learning and assessment within your program? What are the opportunities that you're going to have for learning and assessment? And what are the actual assessments? And finally, the pathway to entrustment. So who's going to decide and based on what? And I don't know how many of you who are here were at Emily's discussion of the EPAC program, but the EPAC program is one of the few programs I would say in our country right now that has actually worked through all of these for the core EPAs for entering residency. And this is based on a clinical competence committee looking at the aggregate of evidence around each individual measurement of each entrustable professional activities. So we said the title here, facilitate handovers to another healthcare provider, either within or across settings, right? Pretty easy. Everybody looks at this. We all have the same common picture, I think, of what this means. And more specifically, we come up with the rationale. Why should this be one of 17 EPAs for pediatrics? Because the healthcare system is complex. There are a commensurate increase in the number of handovers, both within settings and between settings, and the continuity of healthcare providers has decreased over time. That's the rationale for this being a really important one. So then we say, well, what are the functions? Well, if you're the information provider, and by the way, this all comes directly from the literature, and most of this comes, all of this comes with help from the IPAS group. I don't know how many of you are familiar with IPAS, but it was a national study in pediatrics that showed a remarkable decrease in adverse events by the addition of a standardized handover process. And so what we know from that is that these are the critical issues that have to be part of a handover for it to be successful. The communication of situation awareness, illness, severity, action planning, et cetera. And that the information receiver has to be able to elicit clarifying information and then provide feedback to the person who they got sign out from the next day when things didn't go well or they did go well. So if those are the functions, then we would say that these are the critical domains of competence. Patient care, practice-based learning and improvement, that's the issue of giving feedback and continually improving one's handover skills, and then the interpersonal and communication skills. And within those domains, right, those are the domains. Yeah, Bryce, please. No, that's there. 1, 2, 3, 4, 5, 6, 7. What am I missing?
Interprofessional collaboration. It's the difference between the 8 at the UME level and the 6 at the ECG.
Thank you. Yeah. I'm missing. No, it's actually interprofessional. It's specifically related to communication with other health professionals. Communication, teamwork, understanding roles, and respect for other professionals outside of one's own professional. So inter, not intra. And I apologize. The reason. Yeah, so it is in the ACGME framework. But when we were looking at creating a robust list for all of healthcare, for all of physicianhood, UME, GME, CME, the feeling was that this was such an important current issue that's not addressed very much. It's hidden in there. It's not easy to find, that we should pull it out as its own. That being said, it's not part of the ACGME framework, and that's why it's not on this thing. So thank you for pointing it out. I'm very impressed that you even found that. Okay, so these were the specific competencies that come directly from the list of pediatric competencies. So organize and prioritize responsibilities, provide transfer of care, communicate effectively with physicians, other health professionals, and there's the example of where it's embedded in interpersonal communication skills. Maintain comprehensive, timely, and legible medical records. And the reason we put that one in critically is because it turns out that if you have both a verbal and a written sign out, it actually is improvement in care over just a verbal sign out. Practice-based learning improvement, the incorporating formative evaluation, feedback, and use of information technology. So those are the 6 that we said were important. Now what you can do, and this is the table that follows this. And this is the only sort of hard part of this talk to follow. So make sure, let me know if you have any questions. But this is one where now what we've done is in the left-hand column, we've put those 6 competencies that I just told you we said are critical to how this EPA is performed. What we can now do in the columns is to create the milestones, not create them, place the milestones, the pediatric milestones for each of those competencies. So if you look across the first row, you're seeing the competency, organize, and prioritize, right? And you're seeing the milestone for the novice level, the advanced beginner, the competent, the proficient, and the master. Everybody with me on the table? Okay, so now each row is one competency and its milestones. Now what happens as we look down a column? As we look down a column, we can actually see the behaviors across the competencies at that level of performance. So if you read the first column, you're reading the behaviors of a novice. And if you read the second column, you're reading the behaviors of an advanced beginner, and the third column of behaviors of a competent person, fourth column of a proficient person, and fifth of a master. Everybody with me so far? And just to show you in graphic form, that's sort of what we're talking about. So you have an EPA. It maps to certain domains of competence, to competencies within those domains, and those competencies are measured by those 5 levels of milestones. So now what you can do is you can use those table columns to paint the picture of a novice, an advanced beginner, a competent, a proficient, or a master doing that EPA. And that's what this is graphically described at. And if you go to the end of the table, so go to the end of the table, and you will see expected behaviors for a novice learner, and then expected behaviors for an advanced beginner, etc. Everybody see that on the table? So if you just take a couple seconds and just read a little bit about the first learner, the expected behaviors of a novice, what you'll see is that we have actually painted a picture based on the milestones. So we've started with the EPAs, we mapped them to critical competencies, we used the milestones for those competencies to say, what does a novice learner actually look like? And what does an advanced beginner look like? And what does a competent, etc.? The milestones end up thus really informing our assessments. What the milestones are doing, as Mike Elward from a paper, from a study he did here said, is they're providing us a guided gestalt. We're moving from pure gestalt, I know it when I see it, I trust this person to do this or I don't, to guided by the milestones. These are the behaviors that I'm expecting to see when I walk into the room. So then you can use those expected behaviors, as we've done and the examples are there, to create vignettes that can now be used as faculty development. So if I were to develop faculty in assessing this, I would show them the vignettes. I would let them see what a learner looks like at the various levels and ask them to try to match learners when they watch them to that. And the final step, the ideal state, is to create video scripts and videos from those vignettes as faculty development tools. And we've done that actually for the handover as part of the EPAs study. Okay, next you got to develop the curriculum. I'm not going to spend a lot of time on this piece, but you do need to figure out, what are the specific knowledge, skills, and attitudes, and the how, when, and why. Where am I going to teach it? How am I going to teach it? How am I going to assess it? When in the program does this one make sense? Who do I need to, which faculty do I need to develop? Because I don't think you need to, none of us. There are probably 10 of the EPAs that I'm not competent to assess. They're not, it's creating a medical home. Well, I'm an inpatient physician. I don't do outpatient medicine. So that's not an EPA I should be assessing. So you need to develop me on the ones that you want me to assess for your program. And then finally, as we said, who's going to make the entrustment decisions? I think it's pretty easy at the graduate medical education level. It's CCCs, the clinical competency committees. We are going to have to figure out a way to do this at the undergraduate medical level and scale it to take sort of what we've learned from the Education Pediatrics Cross Continuum model, which is fantastic, and scale it to, I think we have 920 students in the medical school. So now I'm going to just briefly end with a discussion of why I think these are important across the continuum. So we finally have this concept of agreed upon vision of what the competencies are required for a physician in the 21st century. And we're struggling with how to assess them. And I think EPAs provide a great framework for that assessment, and now we actually have the ability to do it across the continuum. So at the undergraduate level, there's these core and trustable professional activities for entering residency. And these were a group that was charged as a result of the gaps that we talked about between performance of new residents and expectations of program directors, and also a knowledge of what they're doing without direct supervision on day one. I'll give you a quick example. One of our core EPAs for entering residency is to enter orders and write prescriptions, right? How many of you think residents are doing that starting day one of their residency? Entering orders and writing prescriptions, right? Of course they're doing it. Now, let me tell you how many of them are confident in their ability to do that without direct supervision. About 55%. In the graduation questionnaire, in the graduation survey of all graduating medical students, about 55% said they were confident in their ability to enter orders and write prescriptions without direct supervision. And the percentage of program directors who felt that most or all of their residents on day one were able to do it was in the 40s. So we have a problem for certain. And just to show you how I think these relate, this comes from Tracy Fulton, who was part of our core EPA working group. So the EPAs for any residency are a part of, but not the whole picture for expectations for graduation from medical school. You have to take the USMLEs, you have to, in many medical schools, there are mission specific, either advocacy or research or community work type thing, or practice improvement type things. The core EPAs then form the foundation for EPAs for any practicing physician. So I would argue handover communication is an EPA for any physician. And then those serve the foundation as EPAs for specialties. So care of the well newborn would be an example of an EPA for peds that doesn't exist for other specialties except perhaps family practice. These are the 13, and I'm not going to dwell on them because the lists are out there and published, but they're pretty, when you look at them, they're pretty commonsensical. This was definitely not rocket science. And when we had a group of we had a lot of people react to this. We actually publicly displayed it and got comments for 3 months, and specifically went to some patient groups to say, what do you think? Do you think this is reasonable for an intern to be able to do when they first see you on day 1 of their residency? What do you think patients said? They said, are you kidding? They don't do this? That's what they said for the most part. What we said was, we don't know. We think they can do this without supervision. We don't know. And it turns out that many of them they can, but many of them they can't. Many of them they don't feel well prepared. And that's, by the way, I'm not indicting the residents. I'm indicting us, the educators, because we together have to come up with a way to get people to entrustment by the time they go to residency. Yeah. Yes. I would hope that you're confident in your ability to gather history and perform a physical on your own, without somebody in the room, always with indirect supervision, somebody who's going to come in and check your findings. But yeah, I would hope you're confident to prioritize a differential diagnosis, to recommend and interpret common tests. We're not, in the common tests that we've listed are, So interesting that you say that. So here's the the other piece is, we asked program directors, are your new residents competent to do these things? And that was a competence question, not a confidence question. And the competence, their answer was, for some of them, like gather a history and physical, was 90% said most or all can do that. But for many of these, it was much lower. And actually, interestingly, the confidence, this just sort of argues a little bit differently, is that the confidence levels of the students was always higher than the program director's mark of their 100% of the time. When there was a gap, that was the gap. So I think your point is very well taken, and we have to be very careful about conclusions, particularly about confidence. But I actually think, compared to the program director's assessment of their performance, they're, if anything, overconfident in their abilities. The bottom line is, I'm fairly certain right now we have a large gap. We have not for every one of these, but for many of these, we have a large gap. Okay, so then for the specialty, so that's the undergraduate ones. For a specialty, it's what does a pediatrician do every day? And after a 3-year process, iterative process between the American Board of Pediatrics and the Association of Pediatric Program Directors, we came to the agreement on 17 EPAs. And again, I'm not going to go through all of them. What I want to show you, though, these are 17. What I do want to show you, though, is how they may align. Oh, and I should say the other thing that we did was the American Board of Pediatrics worked with all of the subspecialties, had 2 reps from every subspecialty to get together a group to define subspecialty-related EPAs. So every subspecialty in pediatrics, all 14 board certifiable, is that the right term? Board certifiable subspecialties have EPAs as well. And the way that they interrelate is like this. Sometimes there's direct alignment. So the core EPA for students is collaborate as a member of interprofessional team. General Peds EPA is lead an interprofessional team. Subspecialty is the same. So the subspecialist said this was an important EPA for them across subspecialties as well. There were about 7 that they thought continued into fellowship and should stay, obviously, but now within the context of the subspecialty. And the other way is sort of as building blocks, where EPAs are foundational. So if you look at these 4 student EPAs, gather history, perform a physical, prioritize differential diagnosis, recommend and interpret common tests, and enter orders, I would argue that those are critical foundations to the ability in pediatrics to manage patients with acute common diagnoses in an ambulatory emergency or inpatient setting. And most of the subspecialty EPAs have their own EPA that's, the example I gave here is endocrine, manage patients with acute common endocrine disorders in an ambulatory emergency or inpatient setting. So I think you can see that if we could actually begin to incorporate these EPAs at the UME and at the GME level, I think students and trainees and we would get a much better idea of what the building blocks are for development as a physician and what the ultimate performance is and what you really need to be able to do as a pediatrician. Couple final thoughts. I think competencies, milestones, and EPAs, the competencies and their milestones, that's the competencies with their performance levels, and the EPAs are both critical for assessment. So the competencies and milestones give us that telephoto lens. So when somebody's struggling, I can go back to that table that I showed you and try and use it as a diagnostic. What are they missing? My gestalt is things aren't going well. Which component there isn't working? But the EPAs, provide us with a holistic approach, a real panoramic view with this ability to integrate competencies in the workplace. And I think if you go and speak to those of you who speak to your colleagues, the faculty, and the students who have been engaged in EPAC, they will tell you that this has been a great sort of foundation for discussions and for assessment. And that the students feel like they know exactly what it is they're supposed to be doing, and the faculty know exactly what it is they're supposed to be assessing on. And I think most of those students would argue pretty profoundly that they had an amazing year of learning about themselves and their performance in a way that they probably have never had prior to this in their educational experience. So I think, to me, the reason for EPAs is they make sense to us. They make assessment more practical by clustering competencies, so you're not looking at each individual competency. And I want to say, this is really interesting. So the pediatric subspecialty group, the NICU, actually started a pilot for their EPAs. And when they looked at the assessments and where somebody was placed on a milestone, on the milestone level, the 5 milestones, for the competencies that were critical to an EPA, they found a great correlation, right? So if you take the 6 competencies that were critical to the handover EPA, there was really good correlation for where those learners were assessed on those 6 competencies. When they looked at the competency domains, so they looked at all of the patient care competencies, there was not a correlation between where the learners were. So to me, that's pretty amazing construct validity around the concept of an EPA. It's telling you that we tend to actually cluster our performance around activities that integrate competencies more than we do around individual competencies that are part of a large domain. Does that make sense? So that data hopefully will be published shortly, but that was from a communication that I had with the leader of that study. I love that they add trust to the assessment conversations. As I said, we're making trust decisions all the time. This is a nice way to make it explicit. They align what we assess with what we do, and they align education across the continuum. So I come back to my objectives. Hopefully we have done a decent job for you today of developing a working knowledge of EPAs in the context of competency-based education, a working knowledge of the relationship between EPAs, competencies, and milestones. I would feel badly if you're leaving without a better understanding of those 3 concepts and how they interrelate, and then how EPAs might be applied across the continuum. So I thank you. This is a beautiful July 4th in Minneapolis and St. Paul. My first here, and hopefully my first of many. So thank you, and I don't know if we have some time for a couple questions. I have 8:30, so if somebody wants to stay for questions, I'm happy to. Otherwise, I understand that people probably need to go. Yeah, Bryce?
EPAs in undergraduate medical education, and because it seems to me like it's a yes/no decision. Is this an individual entrustable on this activity or not? And so what are your thoughts about how that process is best implemented?
Yeah, so the ultimate decision is a binary decision, but the process of getting to that decision is actually very formative. So what I expect is we'll have multiple episodes of ad hoc or individual assessments of these where it might be 5 or 6 different faculty assessing the history and physical, for example. And then there'll be a group who's used to looking at the aggregate data who puts that aggregate data together and says, we're at the point. So, and if you look at I should have brought a couple slides from the EPAC data, but what you can see is, they start at this level of direct supervision, requiring direct supervision, and then you'll see a couple, maybe out of 3, one of them said, well, they could do this without direct supervision, but 2 still say with direct. And then eventually they get to a point where the last 3 or 5 all said without direct supervision, and that's the point at which the clinical competency says, okay, they're okay to do this without. So I don't know how many you need to do at that level before you can do it. My guess is 3 to 5 is probably fine. And if you're at 3 to 5, particularly if we've decided that you're discerning and can get help when you need it, I think we're in great shape. And either way, it's 20 to 50 times, literally 20 to 50 times the data that's provided to students in the regular pathway. Yes, please.
My name's Wes. I'm one of the pediatric BMT docs. Nice to meet you.
Likewise.
I was just curious, you were talking about now that people are focusing on the EPAs of entering pediatric residence, and program directors are assigning a binary assessment of their entering residence. Have people gone back and looked at how that may correlate to training med schools? Like which med schools that there may be a correlation? If so, are there certain med schools that are overperforming, and what does that mean in terms of what their curriculum and experiences look like?
Thank you. That's a great question. So, and my answer is that, first of all, the core EPAs were published 2 years ago, just published. So nobody's really used them. We have data because while I was at the AMC, I got them to just add questions to the graduate questionnaire. That was how we got to see the baseline data. I would consider that baseline data. We will now have it. Whenever we're doing early data at the AAMC, they are very cautious around applying it to specific schools. They actually like to look at a couple years of data to look for validity evidence before they do that. Once they do, they will allow us to do that so that we can actually see ratings by school. And the way that'll work is I'll get a rating on the University of Minnesota for each of the 13 EPAs, how my students compare, hopefully. The other piece that we can do is we actually send to every program director where our students go. So we have 230 graduates. To all of those program directors, we send a survey saying, how are our students? And we are going to hopefully start to ask them specifically about their performance on the 13 EPAs. So we should start to get data, but right now, that baseline data is just aggregate. Yeah.
So you started out the talk by saying we changed from a time-based program to an outcomes-based program.
Right.
As a fellowship director, if someone doesn't meet the EPAs, does that mean we need to keep them in the program until they do, or how do we do that?
Yeah, so another great question. Here's the way I think this will end up playing out. I think that, so the bottom line answer is yes about keeping them in the program. That if we set criteria that we say are necessary for independent practice, then they need to meet those criteria to go into independent practice. However, there's a big caveat here, and that is these are all new. We haven't worked with these, and it may be that as program directors, as your organization of program directors for your subspecialty get together, you say, you know what, it turns out not to be reasonable that in a 3-year period they can do all 12, 13, 14, whatever you ended up with for your subspecialty. And in particular, we're seeing struggles on these two. And then I think it becomes a conversation with the American Board of Pediatrics about how improvement on those in the practice setting can be expected and part of maintenance of certification. And I know that there are some people at the board who are excited about using this as a Part 4 opportunity. That if you leave and you know that you've been entrusted on 12 of the 13 or 11 of the 13, that one of the things you can do is seek supervision, indirect supervision, but guidance and feedback on 1 or 2 of those and show that you get to a point of entrustment. part of this is, none of this is mandate yet, and it shouldn't be. We have to study this over the next 5 to 10 years and figure out if it's really meeting people's needs. But from my perspective, so far, the early data is really impressive. That this is, it's meaningful, it helps learners, it helps faculty, and it is a better way to look, it's a more valid way to look at assessment of competence in this aggregate, task-based way than when we try to isolate individual competencies and measure them. All right, well, oh, sorry. One more, go ahead.
So, med students are very focused on their grades and rotations. Is it
I've never seen that.
honors or excellence or... But rightfully so, right? Because residency programs are looking at that in terms of resident selection. So
Yeah.
Is there a relationship between the EPAs and the competencies and the grades? Should there be a relationship, or how do you view that?
Great question. So I'm going to say publicly that my goal is to eliminate grades in our medical school within 5 years. I will also say publicly that I can't do that, and no student will let me do that unless I have very meaningful information to provide to program directors so that they want our students. And so I hope to be able to use this kind of data. I will tell you, and Emily I've heard her say this before. Her understanding of the 4 residents who are entering from EPAC is about as strong as an understanding you can get about the capabilities of people, right? It's because it's not because she doesn't try with the others, it's just that medical schools don't supply her with that kind of data. We need to if we can supply people with that kind of data, it'll work. And then the other thing that'll happen is our students will go and, 100% of them will be able to do these things without direct supervision. And so those program directors, what's the best selling point for a med school for you? Perform right?
I have become such a believer in the problem of grades that when I went to the Macy Regional Conference, I said, in front of 200 program directors
and, clerkship directors, I said, grades are a problem and we have to do something about it because it's so clear with our 4 EPAC students just to hear them say, I wasn't worried about if I was going to get honors or excellent. I was just focusing on trying to be a good doctor and learn the things that I need to do to move on to the next level, which is exactly what they should be doing. And when they're worried about looking stupid, they don't ask the questions to improve their performance. They only speak up when they're certain. It's that sort of discernment and trustworthiness, and we don't get the real view, and they can't develop themselves because they're afraid to show where they need development. But it is a huge paradigm shift to go from well, he's pretty smart, honors, he could answer my 5 random pimp questions, to actually really specifically describing what it means to be a skilled medical student who's ready to go on to residency.
Thanks. Yes, please.
So this demands a lot more direct observation.
Yes.
And do department heads know this?
Did Joe leave?
But across all specialties, it just demands a lot more direct observation, and something that we've been struggling to do.
Yeah.
Who do you have do the direct observation? Is it chiefs, which is what some programs do? Is it attendings?
Yeah. Yes and yes. So I think we have to get much more clever about how we do this. The other piece that I would say to you is we have to use our observation time much better. So an example is in pediatrics now on the wards, I spend 3 hours rounding with the team in patients' rooms, watching a lot of what they do. So for students, oral presentation is one of the EPAs. I can do that every day. The second piece is that in the study that the EPAC folks did, the actual time it took for the feedback, the way that they have it set up, is 2 to 3 minutes per episode. So that part is easy. And then the third part is that I think we've been, if we do this right, then we really will be able to have some graduated responsibility. So it's not just saying we're going to entrust. There are sort of three levels to the entrustment to do something without direct supervision, or with indirect supervision only. The first is, I'm going to trust you to do it without me being in the room, but I'm going to recheck everything you did. The second is, I'm only going to recheck key findings. And the third is, I'm available to you still as an indirect supervisor, but I don't need to recheck your findings. So imagine if we got to a point, particularly with that, our goal is that second level, that we're going to be able to let you do it with indirect supervision, only rechecking key findings. You know, right now for the students, most docs are going back into the room and doing everything over again. So it's like double. And I think there's some efficiency to be had if we actually do it the way we say it's doable. Now, the next question you're going to ask me is about billing. And I think that that is still consistent with Medicare laws and thus Medicaid laws also, which is more important for us.
Yeah, just two, we're going way over time, but now it's just the diehard educators who have stuck around and probably don't have to record anymore. But I would say that our experience with EPAC, really the thing that you had to do more director observation than you were doing in the past was gathering a history and physical, which honestly we should be observing more than we are. But I found that I was able to do it in little chunks, go and catch the beginning of a visit or go and catch the tail end of a visit. But the big thing that we did with EPAC is have the students really have ownership for gathering the information about all of their different performance domains. So for some of it, like, can you form a clinical question and find evidence to support the answer? It's just a matter of them bringing like, hey, I brought this article today. This is the question I was answering. Can we talk about it for 5 minutes and then you can give me some feedback? And so some of it is just sort of mapping out and making sure you sample those different points. So I actually found that it didn't take me much longer. In a busy clinic where I'm running around and trying to do a bunch of stuff, you just have to be a little more planful about your time. And I think for us, having the learners really own it was a huge part of it. And then the other thing, which I think is fascinating, is the billing stuff about medical student notes and the way we use the EMR really hamper our students' ability to develop their skills. Like when most of us were med students, you could write the orders and then put the little slash and your senior resident would sign off. So you did all the orders yourself. You got tons of practice and you would write the whole note and then somebody would just sign their name to the bottom. So people actually would read the med student notes. And now we have these side-by-side monstrosities to make sure that we can bill properly. And, I think that's something that nationally we probably need to work on because the medical students are ready to write the notes for us. And they do professionally before they start med school. They work as scribes and write the notes for us. And then as soon as they start med school, they can't do it anymore.
I also, this is a little bit, I don't want to come up, it's a little bit righteous to some extent, but it's also, I struggle when we have students paying $40,000 to $50,000 a year, and to have students leave the midst of a medical school saying they've been observed by a faculty directly twice. I don't think there's an excuse for that. And there are monies that go to the departments from the medical school for medical education training. Would I like to triple it or quadruple it? Sure, that would be great. But, we came here because we love teaching. That's why I come to an academic institution, is because I wouldn't be happy in a community setting with no students or residents. It's one of my joys. So we just got to do more.